Hi, and welcome to Complex Coronary Interventions from the Leeds General Infirmary. This is a case of complex antegrade dissection re-entry technique to treat a heavily calcified right coronary artery occlusion. My name is Dr. Abdul Moses. I'm a consultant cardiologist at the Leeds General Infirmary. 64-year-old man who'd had previous documented right coronary artery occlusion and presented again with CCS class 3 angina symptoms. He had unsuccessful attempts in 2014 and 2015. He had worsening symptoms recently despite optimal medical therapy. He had good left ventricular function with inferior wall ischemia on perfusion imaging and did not have any significant comorbidities. This is diagnostic angiogram from the most recent diagnostic procedure, showing the large dominant epicardial collateral from a large diagonal system, possibly some septals. This is the right coronary occlusion, which appears proximal occlusion, calcified vessel, and fairly ambiguous course in the mid vessel, although the cap is reasonably well defined. This was one of the previous failed attempts. The tortuosity of the vessel, again demonstrated here with calcification. An antegrade attempt was unsuccessful, and on a separate occasion, the retrograde attempt via an epicardial collateral from the circumflex was unsuccessful with possible dissection, with perforation, although this did not lead to any clinical sequelae, and the patient was managed medically. So he returned for a third attempt. This procedure was performed using biradial 7 French access. The strategy was to initially attempt retrograde via septals. If this failed, to move on to antegrade dissection re-entry, and if this was unsuccessful, then to perform a retrograde procedure via the epicardial collaterals from the LAD. So this is the procedure. So initially, the left radial artery access was straightforward. His right radial was small and was spastic, and required this balloon tracking technique to advance the 7 French guide catheter. So the 7 French flowed to left 3-5 from the right radial to the left coronary, and a 7 French AO1 from the left radial. These are the setup images showing about around a 20-meter occlusion, calcified tortuous mid-right. This is the REO view, looking to see if there are any septals. You can see there's potentially some septal collaterals, although the dominant collateral is these epicardial vessels from the diagonal. The occlusion length is not so long, so initial plan was to attempt retrograde via these septals. So started off with septal surfing. So here we used a Turnpike LP microcatheter and initially probed the third septal using a Sion wire. Then managed to cross one part of this septal with a Suo wire, but again could not find a distal connection. So moved on to the first septal, and this is a tip injection. Again, not showing clear connections, although often it is possible to cross septals which are not clearly well visualized. So it is always worth an attempt at trying to wire septals even when it's not clearly visible with contrast injection. And my practice, I always try and attempt septals prior to moving on to any high-grade epicardial collaterals. In terms of why choice for retrograde wiring. You usually start off with a C-on wire and then move on to a CO3 if it's tortuous, maintaining, really reserving the CO3 for the epicardial collaterals. So here we are again, trying to wire. And this is again a C-on wire. So advance the turnpike LP to provide a little bit more support. But again, unable to find an obvious path to the distal right coronary artery. So I then moved on to antegrade wire escalation with view to dissection and re-entry. Interestingly, this was just a C-on blue wire, which in fact appeared to cross the proximal cap, clarified the ambiguous course. And in fact, in the REO view, we can see the tortuosity and calcification vessel, but in fact, the occlusion length is actually relatively short. You can see bridging collaterals filling the distal vessel. But the issue here is angulation at a very calcified occlusion. And a brief attempt was made to try and wire this. And then took a turnpike spiral microcatheter. And we were able to deliver this to the proximal cap and attempted to wire this initially with a pilot 200 wire. Which is a polymer jacket wire of medium tip load. During these procedures, we check ACT every 20 minutes, as this case was ACT guided heparin. So here is the attempt to wire the vessel. So this was a pilot 200 wire in the first instance. You can see that this is a very calcified point in an angulated vessel, and pushing on this leads to backing out of the microcatheter and the guide catheter. We appreciate here again. Okay, so unable to cross with the pilot 200. So we then stepped up to the Confianza Pro 12. So this is an Antegrade wire escalation technique, and even the Confianza Pro 12 struggles to make any progress through this proximal cap. And here it's more of a drilling technique, trying to make some inroads into the proximal cap and then de-escalate to a less penetrative wire. After some drilling, they appears to have made some progress, and there it just seems to pop. The test shot here shows that this is probably outside the line of the vessel. So this is withdrawn. It is important to note not to follow wires with microcatheter if you're unclear if you're in vesical architecture. A wire exiting a main vessel usually does not cause any harm. It's usually then if you follow with a microcatheter is when you make the hole. So if in doubt, do not follow with a microcatheter. So having exhausted sort of antegrade wire escalation technique, it was then time to move on to dissection, persisting with trying to wire this vessel is more likely to lead to harm, given the angulation and calcification and potential risk of perforation. So in fact, it is safer to try and perform a dissection procedure now, try and get a knuckle going to try and blood dissect past this point and then re-enter. So here, this was a field XT wire. And in fact, this has tracked into the side branch in a subintimal plane. I've brought it back, trying to wire or at least trying to form a knuckle in the main vessel instead. So you can see just from a dry cine that the knuckle is in line with the calcium. A guide extension catheter has also been introduced. So this is a 7 French Trapliner. And despite having this 7 French Trapliner, really is a struggle to get moving the microcatheter through this point. Really the key is to try and get more wire moving forward to the distal bed. So again here pushing on the Fielder XT to try and knuckle past this point. You can see the resistance here. So then the Fielder XT keeps finding this side branch in a subintimal plane. And in fact, this is confirmed with a gentle contrast injection. That wire is actually tracking the marginal branch in a likely subintimal plane. So then decided to leave this wire here and use this wire as support and introduce a second system. And if I can then balloon on this wire, forming a parallel anchor balloon to a separate system, and trapping a microcatheter to do something called a power knuckle. So here we dilate the proximal vessel, deliver the Trapliner. So that's delivered nicely as a calcified occlusion. And again, despite having the Trapliner introduced quite far, it is impossible to pass any balloon through the calcified point. This is an Ikazuchi 1mm balloon and still makes very little progress and leaves everything backing out. So clearly it was not possible to dilate this tract. So at this point we just blew the 1mm balloon to high pressure, causing it to burst, in the hope of causing some dissection planes. So here we are then, following that, introducing a second wire with the turnpike spiral, and this is now a gladius wire. I can see from the shape this has likely entered the dissection planes caused by the granuloplasty of the 1mm balloon, but again unable to make any progress due to the calcification in the vessel. So here then the microcatheter is removed. And the Trapliner is also removed, and then this allows us to introduce a 3.5mm NC balloon on the Fielder XT wire, which is subintimal in the marginal. This then traps the second wire, the gladius, and we can now introduce the turnpike spiral again. So here's a turnpike spiral coming in. The balloon is deflated, turnpike spiral is delivered. The balloon is now inflated again, now trapping the turnpike spiral and anchoring it to the vessel, and this is called a power knuckle. And then you can see, following this maneuver, it is then fairly straightforward and easy to knuckle past the occlusion point with the gladius. And this is confirmed in the RCA view. It is always important to check in orthogonal views to confirm that you are in line with the vessel. So you can see it confirmed with retrograde injections. We are in vessel architecture. The anchor balloon or parallel anchor balloon is then deflated, and the turnpike spiral is then advanced. And you can see how much easier it is now to cross now that we are in the subintimal space and essentially bypassing the luminal calcium. Again, the anchor balloon is inflated, and we try and knuckle further, and this is now a Fielder XT, and here this knuckles nicely past the mid vessel. So for fluoroscopy, the vessel is heavily calcified, so there did appear to be a spot of vessel at the distal, proximal to the distal bifurcation, which was not as calcified, and this appeared to be the best landing zone for re-entry. So the plan was to try and get to that point rather than doing attempting re-entry higher in the vessel. So this is again the turnpike spiral is taken on, and again a Fielder XT knuckle. We're now in a good position. So now, to provide more support, we now introduce the time to trap off the turnpike spiral. So the balloon inflator acting as a trapping balloon now. And now it's time to introduce the Trapliner. So this now has dual purpose. So it increases the support significantly to try and deliver devices, particularly through this angulated vessel. But it has the second purpose of, in fact, plugging the entry into the subintimal space, preventing the hematoma from expanding. So you can see here the Trapliner is now fully advanced. And if you can see the hemodynamic monitoring, there is no pressure trace, which is the blue line from the right coronary artery, and this is because the Trapliner is well into the vessel and damping the pressure trace. So with a Trapliner, it is then easy to introduce and remove devices. So this is a CrossBoss catheter now, and here it is spinning forward to blunt dissect and produce a nicer area for attempted re-entry. You could just try and deliver a Stingray after knuckling. However, that can, after knuckling, the space created can be quite large, and it can be difficult for the Stingray balloon to conform to the vessel wall. And often this is nice to finish the knuckling portion with a CrossBoss to finish the dissection and then to deliver your Miracle 12 wire. So this is then the Miracle 12, which is nice supportive wire from tip to core. This then allows us to deliver the Stingray balloon. As you can see here, two dots of the Stingray coming down just here. So the Stingray is now delivered, and this is again a much easier process having a Trapliner in the vessel. As you can deliver and trap off the devices fairly easily. So we then inflate the Stingray balloon to 6 atmospheres, and actually we are very well aligned with single balloon scene, and I'm confident that the Stingray is actually below the vessel, having previously seen that the CrossBoss was below the vessel at this point also. So yeah. So now the aim is to puncture into the vessel, and I elected to use a Stato 20 wire here directly, given the calcification. So this is a 20-gram wire produced by Asahi. So here's the Stato 20. The added advantage of the starter is that it's a 300 centimeter wire, which makes removing devices easier. And here we are, the starter punctures out of the Stingray and into the vessel. This was a first pass puncture. In this view, we look good. So it's always important to take multiple views before committing. So here, initially it looks out, but in fact, you can see that actually the Astarte is in a small branch, and is in fact in the true lumen, but it's actually got into a small proximal branch prior to the bifurcation. So to demonstrate this, then I pull back the Astarte to try and wire the proximal branches. Unfortunately, I didn't have much of a curve on the Astarte because the curve we put on it was for the puncture and not for wiring the bifurcation. However, I was in a small vessel and didn't really want to perform exchanges with an Astarte wire parked in a small vessel with risk of perforation. So I really wanted to try and get the Astarte into one of the bigger branches. And following some manipulation, here we go, we're able to wire into the PLV. Confirmed with contrast, contralateral injection. The Astarte wire is now in the PLV. Again, confirmed it with different projections just to make sure. And that's clearly in the true lumen. So we then deflate the Stingray balloon. And remove this over the Astarte wire. Using the Trapliner to trap off also, but also with the added benefit of having the 300 centimeter wire for more control. So then the turnpike spiral was then reintroduced. The Astarte was removed, and a workhorse wire was placed distally. Very important to always replace your CTO wire with a workhorse wire to work with, particularly stiff wire. This is now clearly in the PLV. I was quite keen to have the wire in the PDA, given that this appeared to be the larger vessel. So here we simply left the Corsair distal to the re-entry zone, brought back the Sion blue, and was able to wire the PDA. Alternatively, we could have taken a dual lumen catheter, leaving the POV wire and using the dual lumen to wire the PDA. That would have been an alternative technique here. So after wiring the cyan blue, the turnpike spiral was removed. The occlusion length was pre-dilated, a 30mm balloon. And the Trapliner was introduced further. You can still see that there's no bleed pressure trace, so there is clear damping of pressure, which has helped maintain the size of the distal vessels and has prevented significant hematoma from developing. So we then IVUS perform intravascular imaging. This is a Boston OptiCross catheter to size the vessel adequately, and on intravascular imaging this was a 3.5 to 4mm vessel. So we started obviously with a long 3.5mm, 3.5 by 48mm stent, overlapped more proximal with another 3.5 by 48mm stent, and finally a further 4 by 18mm stent to the ostium. So it's a gentle test shot just to make sure we land the ostium. And post-dilations are performed with a 4mm NC balloon to high pressure using IVUS guidance. And before taking any final injections, it's always important to make sure you de-air the guide catheter, as after all the prolonged damping, there will be often lots of air entrained. So make sure you bleed back the guide catheter fully, make sure there's no air. And following high pressure post-dilations, we'll now show you the final result. This is the final result, showing an excellent result with TIMI3 flow into all the branches. Thank you for joining us for this case presentation.